everybody, and welcome to Patient Pulse. We're thrilled to welcome Dr. Catherine Lindley for the second part of our Women's Health series. She will be discussing heart disease and blood clots in pregnancy. Dr. Lindley is an associate professor of medicine and an associate professor of obstetrics and gynecology at Washington University in St. Louis. She's a clinical investigator specializing in cardio-obstetrics, and she's also the current chair of the Cardiovascular Disease in Women Committee of the American College of Cardiology and a member of the ACC Cardio Obstetrics Work Group. So thank you, Dr. Lindley, and please take it away.
Well, thank you so much for inviting me to give this very important presentation. I do not have any financial disclosures. Today, we're going to be discussing several important topics, including the different types of heart disease that may be encountered during pregnancy, different common cardiac complications of pregnancy, some of the long-term cardiovascular sequelae of pregnancy complications, the importance of postpartum care, and the contraception options for women with heart disease. There's a rapidly growing population of women with cardiovascular disease during pregnancy, and this is true for a variety of reasons. Number one, over 90% of women who were born with congenital heart disease are now surviving to childbearing age because of advances in medical and surgical techniques, and their risk of having complications during pregnancy is very heterogeneous. So some women have no higher risk than the general population, and other women have a risk that is potentially life-threatening. So it's very important that these women be evaluated before pregnancy so that they can accurately be given an appropriate risk assessment to determine how safe pregnancy will be for them, and then they could be managed during their pregnancy and delivery. Other women who weren't born with congenital heart disease are more frequently at higher risk for encountering cardiac problems during pregnancy for a variety of different reasons. Many women are now having children at older ages, which puts them at higher risk of having underlying cardiac risk factors. There's a higher risk, therefore, of having heart attacks, hypertension, diabetes, and obesity. And therefore, women have higher rates of preeclampsia, peripartum cardiomyopathy, and other obstetric complications during pregnancy and delivery. We encounter many different types of pregnancy-related cardiovascular disease. This can include cardiovascular disease that is present before the pregnancy, including congenital heart disease or diseases that women were born with, cardiomyopathies, which might include genetic or inherited types of cardiomyopathies, or coronary disease or diseases of the heart arteries that women may have experienced prior to the pregnancy. Other women who went into pregnancy without any known heart problems might have developed new heart problems during the course of the pregnancy, delivery, or period after the pregnancy. And that can include heart attacks, heart failure, and blood clots or thromboembolism. Furthermore, women who have pregnancy complications such as preeclampsia or gestational diabetes are then at risk of developing future cardiovascular complications such as high blood pressure, heart failure, coronary artery disease, and strokes. It's important when caring for women with heart disease that we take a multidisciplinary approach. So there are many different people who need to be involved in the care of a woman who's going through pregnancy who has an underlying cardiac condition. This includes a high-risk obstetrician, an anesthesiologist who is trained in managing patients with cardiac problems, and a cardiologist who has expertise in taking care of women going through pregnancy. Sometimes other physicians are also important, such as neonatologist or pediatric cardiologist if the woman's baby also has cardiac problems. Sometimes a psychiatrist or a geneticist needs to be involved in the care as well. So sometimes there are many different people that need to be involved in the care to ensure that mom and baby both have a healthy outcome. It's important that women who know that they have cardiac disease or are high risk for developing cardiac disease actually start their pregnancy care before they ever become pregnant. These women should come in and see both a high-risk obstetrician or maternal fetal medicine specialist and a cardiologist who has expertise in taking care of women with cardiac problems during pregnancy when they're thinking about becoming pregnant. And this can allow us to help assess what their risk of pregnancy is and get them optimized to reduce their risk of complications during the pregnancy, as well as to plan for a healthy pregnancy by adjusting medications, perhaps doing additional imaging or having them undergo procedures before the pregnancy to optimize their risk. They'll then be followed by these physicians during the course of the pregnancy and plan for the delivery, which might include determining the optimal timing for the delivery, the optimal location for the delivery, the optimal type of delivery, so vaginal delivery or cesarean delivery, and the best type of anesthesia for the delivery, as well as the best place for mom and baby to recover after the delivery. Sometimes cardiac complications do occur during pregnancy despite our best intentions, and being managed by a team of doctors who are used to taking care of patients with lots of cardiac risk factors will be able to identify and treat these complications quickly. And most importantly, it's very critical that patients with cardiac disease or who are at risk for cardiac disease think very carefully about what method of contraception they're going to use, because it's important that they choose a method that's going to be both safe for their underlying cardiac condition as well as very effective to help them plan their pregnancies. One of the complications related to the heart that can occur during pregnancy or after delivery is heart attacks or coronary artery disease. The most common type of heart attack that occurs during pregnancy and after delivery is actually an unusual type of heart attack called spontaneous coronary artery dissection, or SCAD. This is a type of heart attack that occurs due to a tear in the wall of the heart artery. Instead of occurring related to a rupture of a cholesterol and calcium plaque in the artery, it occurs due to basically a break or a tear in the wall of the artery, which causes a blood clot to occur in between the layers of the heart artery. Although this is a rare cause of heart attack in general, it's the leading cause of heart attack in premenopausal and pregnant women. And it's often challenging to diagnose and treat. We should always think about it if a pregnant or recently pregnant woman comes to the hospital with symptoms concerning for a heart attack. There are certain risk factors for women to develop a heart attack during pregnancy or after delivery. Women who are older than 30 years of age, Black women, women who are overweight or obese, women who have diabetes, tobacco use, or high cholesterol, women who have a strong family history of cardiovascular disease, and women who have hypertensive disorders of pregnancy, such as preeclampsia, women who have previously had a coronary artery dissection, and it appears to be slightly more common in women who undergo a blood transfusion or who have an infection. Another complication that can occur during pregnancy is heart failure. Now, this can occur in women who already have underlying cardiac problems, and this is basically a condition where the heart muscle becomes weak and the body becomes overloaded with fluid, and women become swollen and short of breath. However, it can also occur in women who previously had no cardiac problems, and this is a condition called peripartum cardiomyopathy. Fortunately, this is a relatively rare problem. It occurs in about 1 in 1,000 to 4,000 births, but it is more common in Black women, in women who are pregnant with twins, in women who have preeclampsia, and in older moms. What happens in this condition is we believe women begin with a normal heart, but because of hormone changes of pregnancy, their heart becomes enlarged and weakened, and they develop retention of fluid and swelling and shortness of breath. The good news is that with appropriate treatment, about 86% of women will improve, but unfortunately between 3 and 10% of women with this condition may die or require a mechanical heart pump or heart transplant. So women who develop shortness of breath at the end of pregnancy or within the first few months after delivery should be quickly evaluated for this condition because it is potentially life-threatening. Another potential complication of pregnancy is blood clots or thromboembolism. A blood clot occurs either in the veins in the leg or the pelvis, or when one of those blood clots in the leg or the pelvis then breaks loose and travels up to the lungs and blocks off one of the arteries that travel to the lungs, which is called a pulmonary embolism. There's a 4-fold increased risk of blood clots during and after pregnancy. There are many changes in the hormones and blood clotting factors during pregnancy and after delivery, and this makes women much more likely to develop blood clots during this period of their life. In fact, the highest risk time of developing a blood clot in the leg or in the lungs is in the first week or two right after delivery. The most common symptoms are either a painful, swollen leg if a woman were to develop deep vein thrombosis or DVT, or shortness of breath and chest pain if a woman were to develop a pulmonary embolism or PE. When a woman is diagnosed with this, typically by an ultrasound of the leg or a special kind of X-ray called a VQ scan or a CT scan of the chest, this requires a blood thinner for the remainder of the pregnancy and for at least 6 weeks after delivery. We also know that women are at higher risk of developing these type of blood clots if they've had a C-section or if they have certain types of genetic abnormalities that can be inherited. Based on some women's inherent risk, they may be placed on prophylactic blood thinner shots during the course of their pregnancy to try to help reduce the risk of developing these blood clots. Now, all of this sounds scary, and you might feel a huge sigh of relief once the baby is here and it feels like your risk of developing complications is over. But unfortunately, that's not the time to feel like you're out of the weeds, because in fact, the postpartum period actually is the weeds. Postpartum period is actually the time when all of these cardiovascular complications are the most likely to occur. Most women are diagnosed with heart failure or peripartum cardiomyopathy within the first 1 to 2 weeks after delivery. As I mentioned before, blood clots in the leg and the lungs are most likely to occur in the immediate period after delivery, and about 2/3 of those heart attacks related to coronary artery dissection occur after delivery. So it's particularly important that you pay close attention to your symptoms in the first few weeks and up to the first few months after you deliver, and you contact your doctor immediately if you develop any of those symptoms. Some of the risk factors for developing these cardiovascular diseases include being of non-Hispanic Black race. In fact, we know that Black women are about 3 to 4 times as likely as white women to die of cardiovascular disease in pregnancy. We know that older age, particularly older than age 40, puts women at higher risk for developing maternal cardiovascular disease. Obesity, high blood pressure disorders of pregnancy, having chronic diseases like high blood pressure and diabetes, sleep apnea, having delivered preterm, having a strong family history of heart disease, or having previously been exposed to cardiotoxic drugs. So that includes things like previous chemotherapies. Postpartum care is a period of time when we can identify cardiovascular complications in women and treat those conditions and optimize women for subsequent pregnancies and their long-term health. This is particularly true if during a first pregnancy, a woman had a complication or was at risk of having a complication. During that postpartum care period, we can then identify those cardiovascular complications, treat their high blood pressure, screen them for diabetes and high cholesterol. We can counsel women on nutrition and weight loss and identify the best method of contraception for them. And this is really going to require a multidisciplinary care approach, including OBGYN, their primary care doctor, and cardiology, depending on what different components of this care model they need. And by doing all of these things, we can then optimize them for their second pregnancy. And ideally, that will then put them at reduced risk for having complications during their second pregnancy. Following that next pregnancy, again, during that postpartum period, we can screen and identify for cardiovascular complications. Again, repeat all of that counseling through that multidisciplinary care model. And what that can do then is reduce their long-term cardiovascular risk of developing conditions such as strokes, high blood pressure, and heart attacks. Unfortunately, we know that pregnancy complications such as preeclampsia put women at long-term risk of many different cardiovascular complications. This is just one study that shows that long-term complications, including coronary artery disease, which includes conditions like heart attacks, heart failure, aortic stenosis or narrowing of the heart valves, and mitral regurgitation or leakage of the heart valves are all at higher risk among women who had high blood pressure during pregnancy. We also know that these women are at 4 times the risk of developing high blood pressure in the future. They're also twice as likely to have a stroke and twice as likely to have diabetes. And it's not just preeclampsia that puts women at higher risk of future cardiovascular complications. So gestational diabetes, growth restriction of their baby, preterm birth, abruption or sort of a tear of the placenta, obesity or excessive weight gain during the pregnancy, obstructive sleep apnea, and delivering a baby at an age over 40 years. All of these patients need to undergo screening within 3 months after delivery to help reduce their risk of long-term cardiovascular complications. And what that should include is evaluation and counseling on smoking cessation, physical activity, breastfeeding, counseling for cardiac risk factors, taking a good family history, evaluation of blood pressure and weight and waist circumference, and then testing for cholesterol, blood sugar, and urine, and finally counseling on nutrition. Now, lastly, contraception is an extremely important topic for women with underlying cardiovascular disease. The first thing to think about when choosing a method of contraception is this method safe for me? The combined hormonal methods, basically any method that contains estrogen, can potentially put women at increased risk for blood clots. So that includes the pill, the patch, and the ring. There are several conditions that put women in a category where they absolutely should not or probably should not take that medication. However, it's important to recognize that these birth control methods are still lower risk for blood clots than pregnancy. So if you fall into one of these categories and you're taking one of these methods of contraception, it's still safer than pregnancy in terms of blood clot risk. So you shouldn't stop it before choosing an alternative method. The conditions that can put women at higher risk of developing blood clots when taking a combined hormonal method of contraception include women with pulmonary hypertension or high blood pressures in the lungs, or a Fontan, which is women with a single ventricle in their heart, women with atrial fibrillation or atrial flutter, which is a heart rhythm condition, women with mechanical heart valves, women with a shunt lesion, such as an ASD, women with coronary artery disease or an aortic dissection history, women who've had a blood clot in the past, and women who have heart failure. The other thing to think about when choosing a method of contraception is, does it work? There are really 3 different tiers of effectiveness in birth control methods. The most effective method of contraception are those that are less than 1% likelihood of women getting pregnant over the course of a year. And that includes permanent sterilization, which is getting your tubes tied, or your partner getting a vasectomy, or the long-acting reversible contraceptives, which we'll talk about in just a moment. The second tier of effectiveness are those that have a failure rate of 6 to 12% over the course of 1 year. So 6 to 12% likelihood of getting pregnant. And that includes the combined hormonal contraceptives, so the pill, the patch, and the ring, and progesterone-only contraceptives, or sometimes we call that the mini pill. The third tier of contraceptives are those that have a failure rate of 12 to 24% over the course of 1 year. And that includes barrier methods like condoms, the diaphragm, withdrawal method, and fertility awareness methods like natural family planning. Now, barrier methods such as condoms are extremely important for helping reduce the risk of infections. So we do recommend using those in addition to other more effective methods of contraception. And then if women are using no method of contraception, the likelihood of becoming pregnant over the course of 1 year is about 85%. Now, the long-acting reversible methods of contraception, there are really 3 of them. There are 2 types of IUD, or intrauterine device. There's one method which is called the levonorgestrel impregnated IUD. There are 4 different brands of that now, and it's basically a small plastic T-shaped device that has a little bit of progesterone in it, which fits up inside the uterus, and it secretes a small amount of progesterone that basically just affects the uterus itself and doesn't really have much in the way of systemic effect. There's also a copper IUD, which has no hormones in it, and then there's a etonogestrel impregnated rod. It's a small plastic rod that goes underneath the skin and the upper arm. The great news is that all of these methods are actually more effective than getting your tubes tied or a tubal ligation. None of them contain estrogen, so none of them carry any increased risk of forming blood clots. So even if you have a mechanical heart valve or you've had a blood clot before, they're still safe to use. They're all completely reversible, so you can get them removed in your doctor's office and get pregnant typically the following month. And they're FDA approved for 3 to 10 years. I typically do recommend these methods of contraception for women with moderate or severely complex types of heart disease. For women who have genetic varieties of clotting disorders, I would strongly recommend staying away from the estrogen-containing methods of contraception. All of the long-acting reversible contraception options are the most effective and they're completely safe. So the key points that you should take away from this are that counseling on contraception and pregnancy risks should really become early, even before you're planning to become pregnant. Most patients can actually do quite well with pregnancy if they have the right team in place. Postpartum is the highest risk time, so postpartum care is very important. And women should consider long-acting reversible contraception as first line because they're very safe and it helps them really effectively plan their pregnancies. Thank you very much for your attention.
Thank you so much, Dr. Lindley. That was a wonderful overview. And thank you to all of our listeners for tuning in to Patient Pulse. Please join us again next month for part 3 of this series, where we will be actually talking about blood clots in menopause. Thank you very much.